We're going to begin with Professor Naomi Zewde, who is an assistant professor in the Department of Health Policy and Management. Please welcome me in bringing on Professor Naomi Zewde.
Hi. Anyway, great to be here. I'm Naomi Zewde. I just started here at FSPH in September, and I'm really glad to be here. So I'm going to talk a little bit about equity and then finish off with some of my newer work. So basically, yes, as our moderator introduced, equity is a huge problem in the United States, and we're particularly bad about it in our healthcare system here. So low income, meaning below median households, so nearly 40% of American households within 1 year avoid going to the doctor because of cost. And it's actually better to be lower income in these European countries than to be higher income in the US because it's so expensive. We spend a lot of money on healthcare, right? So the U.S. is quite an outlier. This is as a percentage of GDP on the left. But however you measure it, we spend a lot more on healthcare. And yet, we get a lot less for it. So we get less health, right? We're an outlier in the opposite direction in terms of life expectancy at birth, higher than average, chronic conditions. So we get less health. But we also get less health care. So we have fewer physician visits per capita, fewer physicians per capita. So many different measures. Shorter average length of stay in the hospital, conditional on diagnosis at admission. We have fewer hospital beds. We have a lower occupancy rate of those beds. So we use less care. We just spend more on it. So in economics, that's a problem. It's very inefficient. So usually we kind of get together every time there's a presidential election to talk about, what are we going to do about this problem? So the last, big push and big source of progress was the Affordable Care Act. So we reduced rates of uninsurance pretty substantially, almost by half. We did that through expanding private insurance through the non-group markets and expanding eligibility for public coverage in Medicaid. And each of those kind of had, their own issues that now the work is to improve upon. So in the non-group markets in the private insurance arm, we had just really high deductibles. So for, among people who were uninsured prior to the ACA, kind of that prime group of people we want to draw into coverage, it's cheaper to file for bankruptcy than to reach the deductible of the subsidized, benchmark tier of coverage for about 1 in 4 previously uninsured adults. So it didn't provide a lot of financial protection for this population. Medicaid, that's not the problem in Medicaid at all. We have a huge literature showing all of these downstream financial benefits to households from the expansion of Medicaid. Reductions in the rate of poverty, reductions in the rate of home evictions in the US. There's a lot of different indicators, but Medicaid has its own inefficiencies involved. So I think that Medicaid is doesn't have the presence in our public conversations that it probably should. It's a huge source of coverage, actually the biggest in the US. It's mainly administered by states, and the federal government chips in half. That half is the third largest federal domestic expenditure behind Medicare and Social Security. So it's a really big, important program. So most states administer this program by contracting with private insurers, about 72% of beneficiaries. So basically the state pays a per person per month fee to the insurer, who then acts like an insurer. They network providers, do prior authorizations, and they finance and deliver care. And the reasons behind it have never really been clear in the evidence. So if you look in legislative debates, so in North Carolina, they switched over very recently in 2021. They tend to cite fiscal savings, but most of the literature doesn't evidence that. And I would argue that that's because there's little room for consumer competition. I teach economics, if you haven't noticed. But the thing is, once the state chooses to contract with one of these insurers, they have to provide a basic package of benefits. It's a safety net program, right? So from consumers' perspective, there's not that much choice. So the setting of standards really has to happen at the state level. And so in order to do that, I think the first step is oversight and monitoring. And then the second step is, okay, where can we be better? And how do we inject some of that competition for firms to try to, have a reason to strive to do better as well? But that's really hard to do. So we've submitted some Freedom of Information Act requests recently, and I think this is the first place for us to move forward is basically, as it says, like in that purple box on the right, they just don't maintain this information regarding, how institutions allocate their funds across medical care and different administrative categories. So that's our first step for this year. But more generally, I think that, making progress on health equity in the U.S., it's really important for us to beef up our public systems because the fact is our public policies play a really important role in regulating and administering and financing healthcare. So this is work from Alice Chen and Emily Oster, but it shows that infant mortality is one area in which the U.S. really lags behind peer nations. And you really see the biggest gap amongst, disadvantaged populations, so lower income households. So they are very much affected by, our progress towards equity. But in fact, even amongst higher income households in the U.S., so the top 1%, top 5% of counties frequently fare less well than average residents of other nations in OECD countries. So really beefing up our public systems and making that kind of progress in terms of equity and financing, to bring it back to the beginning, it's going to be better for all of us. Thanks.
Thank you, Dr. Zewde. It's my pleasure to welcome Dr. Lara Cushing, who is an assistant professor in the Department of Environmental Health Sciences and the Karin and Jonathan Fielding Chair in Health Equity at UCLA.
Thank you, Dr. Mimiaga. So I'm an environmental health scientist, and much of my work is in the realm of environmental justice, which is I think why I was invited to be on this particular panel. So I want to talk a bit about environmental racism, which is a term coined by Reverend Ben Chavez, pictured up here on the left, during a protest against a major landfill for PCB hazardous waste that was being sited in rural Warren County, North Carolina in the 80s. And really this event gave national attention to an issue that communities had been raising for a long time, about the disproportionate siting of environmental health hazards in communities of color. And supported now by many decades of also academic research, backing up these assertions that has found that people of color are more likely than white people in the United States to live near a whole slew of things that you don't really want in your backyard. Hazardous waste treatment facilities, power plants, breathe dirtier air, drink dirtier water, and lack amenities that promote health like green space. And so this has, I think, it contributes to one piece of the story of why we have such stark inequalities in health along race and ethnic lines. It's more than just environment, but you may have heard the term, your zip code is more important than your genetic code in terms of determining your health and your life expectancy, because the neighborhood you live in really does matter, and the physical environment is one part of that. And if we look historically, this is work by Elizabeth Wrigley Field. You can argue that racism really is more deadly even than COVID-19, because even amidst the pandemic, mortality for white Americans was still lower than it has ever been among Black Americans. So essentially, you can see how life expectancy for Blacks has lagged behind that of whites for almost every year since 1900. The one exception was during the 1918 influenza pandemic. So that gap, is larger than the toll that COVID-19 has placed on life expectancy among the white population in the U.S. So as environmental health scientists, we spend a lot of time thinking about how one pollutant source or one particular chemical impacts health. And proving that is actually very difficult. And we tend to regulate one chemical at a time, one pollutant source at a time, to try to protect population health. But the environmental justice movement and this disparity in health hazards, environmental health hazards experienced by people of color really requires us to think a little more holistically in this environmental health disparities framework, which was actually put forward by our own Dr. Karin G in community health sciences, along with Devin Payne Sturgis, who's at the University of Maryland, pointing out that, we really, if we want to understand how social inequality drives health disparities and the role that the environment plays in that, then we need to be thinking not about one hazard or one pollutant at a time, but multiple of them, because these pollutant sources tend to cluster in disadvantaged communities. And in reality, nobody's exposed to one chemical or pollutant at a time. And chronic social stressors, things like malnutrition, inadequate housing, the stress of living in a racist society can actually exacerbate the effects of pollutants on your body and result in more, further aggregate the health impacts. So that's sort of the framework for a lot of my work. I wanted to share kind of two projects where we've done research in this realm, but also tried to translate it into tools that could be used to inform regulatory policymaking to try to address environmental racism. So what's shown here is zip codes in California ordered from left to right on the left graph by the proportion of their population that identifies as non-Hispanic white. And then on the y-axis are indicators of residential proximity to a number of different environmental health hazards, everything from agricultural pesticide applications to diesel particulate matter coming from heavy-duty vehicles, air pollutants, et cetera. And you can see basically if the curve falls above that blue line, that means it's a regressive distribution. Zip codes with higher proportions of people of color living in them experience more of these things in their backyard. And we found that was true for every single one we looked at. So for example, the orange dot there shows that over 95% of agricultural pesticide use in the state is located in the 60% of zip codes with the highest proportion of people of color. And it's not explained by income, because if you reorder the zip codes by income, the pattern is much less consistent, as shown on the graph on the right. Another example here relates to drinking water. So we found, we estimated drinking water quality for all Californians living who are served by public water systems, and also those who are beyond the service area boundaries of agencies like LADWP and are drinking directly from the groundwater via a private or domestic well. And we found that for every 10% increase in the proportion of the population that identifies as Latinx, they experience a higher likelihood of having one of these three contaminants in their drinking water at elevated concentrations above half the regulatory standard, whether you lived in a community water system or in one of these domestic well areas. So again, trying to look at multiple contaminant framework, because we have several issues with drinking water quality in California, and there are actually many more drinking water contaminants that it would be great to look at, but we didn't have data for. So for both of these tools, both of these projects informed kind of data tools, and I haven't been keeping track of time, so please flash me if I'm going way over. But so the second project I shared, was a collaboration with the Community Water Center and UC Berkeley. Community Water Center is a water justice organization in California that was very instrumental in passing symbolic legislation, making California the first state to legislatively recognize the human right to clean and affordable drinking water. And so all of the data that we gathered for that project is accessible via this tool, which has been used by advocates to, it shows you levels of drinking water contamination, which are very hard to figure out if you're just an average person. until recently. And these have been used by communities to advocate for things like better protection for domestic well communities in groundwater basins that are being overdrafted, which may concentrate contaminants in domestic wells. I'm going to skip over this. For that first project I shared, I seem to have put my slides all in the wrong order, really informed the development of this tool, CalEnviroScreen, which is published by the Cal EPA, Office of Environmental Health Hazard Assessment, which integrated all of those indicators of residential proximity to environmental health hazards that I was showing you before, along with indicators of social vulnerability to derive kind of a geographic environmental justice screening tool score called the CalEnviroScreen Cumulative Impact Score. The work I showed you went into the development of this tool, which is now on its 4th iteration, and the list of things going into it has gotten longer than what I showed you a few slides ago. But this tool is now being used to guide investment, compliance, and enforcement activities and essentially direct resources towards communities that are disproportionately impacted by multiple of these environmental health threats. So that's kind of how, seeking to leverage research that can better inform regulatory policymaking in the environmental health realm to address longstanding problems of environmental racism and promote health equity. So I will stop there. Thanks.
Next, we'll hear from Kathryn Kietzman, who is the Director of Health Policy Programs and Senior Research Scientist at the UCLA Health Policy Research and Associate Researcher of Community Health Sciences.
Good morning. Thank you for the introduction. Great to be here. I'm fortunate to have a researcher appointment at the School of Public Health and Community Health Sciences, but also to work at the Center for Health Policy Research. I don't always get up to this part of campus because my office is there, but then nobody's in their offices anymore, are we? I don't know. So I'm going to zoom out a bit, and what I'd like to talk about here is not so much about a specific research topic or area in health equity, but to talk about a broader effort to move from an understanding of health disparities to the opportunity to advance health equity in our communities. So when I assumed the role of director of the Health Equity Program at the Center for Health Policy Research about 1.5 years ago, we made a very intentional decision to change the name from health disparities to health equity. And we made this decision because we wanted the name to reflect a more actionable and aspirational program, where in addition to generating evidence, documenting existing disparities in health and healthcare outcomes, we also wanted to contribute to the process of identifying and advancing solutions to moving data forward to achieve health equity. As many of you may know, the Center for Health Policy Research was founded in 1994 by the late Dr. E.R. Rick Brown, and he had a long-range vision and commitment, passionate commitment to the democratization of data. Almost 30 years later, the center works to continue and expand his legacy and this commitment, now under the inspirational leadership of Dr. Nunez Ponce. So the democratization of data, I always trip on that word, comes in many forms, but at its core, it's designed to put data in the hands of those who most need it and to accelerate the translation of data to action. So with that as a backdrop, over the next 5 or 6 minutes, is that what I have left? I would like to think through with you some of the essential ingredients of a program to advance health equity and to illustrate these components with some current examples from our work at the Center for Health Policy Research. So we can certainly start with the need for data, but we need to think carefully about what types of data we need and who needs to be at the data table. In other words, we need to be inclusive in all phases of the research process. We also need to ensure that the data that we gather and analyze is representative and easy to access. Once analyzed, an additional step is needed. The findings then need to be translated to policy and practice. And finally, In order for our efforts to be sustainable, we must support the next generation of health equity champions. In recent years, there's growing recognition and support for opening up the research arena to be more inclusive. Being more inclusive means ensuring that the voices of those being studied are part of the research process itself. It means engaging with and learning from individuals to understand what matters to them, what issues are the highest priority within their communities, and to involve diverse stakeholders in both the identification of the problem and the potential solutions. It also means collaborating to develop and implement culturally appropriate and sensitive approaches to gathering, analyzing, interpreting, and disseminating information. In addition to the what information we need to gather, we also need to think carefully about how we should collect it, who should collect it, and what methods should be used. A more equitable research enterprise is also one that is expansive, inviting representation that spans academia and community and reaches across disciplines, professions, and generational divides. And the research projects developed should reach a broad and diverse audience. In addition to being inclusive, we need to ensure that the data is representative. This means stepping back to consider where are the knowledge gaps, whose story is not being told, what are the consequences of these gaps? Data need to effectively represent the population groups for which it bases its claims. These data are used to identify needs, to make decisions about what interventions are appropriate, what programs are needed, and how resources are allocated. Gaps in representative data perpetuate health inequities. One example is evidenced by the experience of the Native Hawaiian and Pacific Islander community. For decades, the health disparities they experience have been hidden due to a lack of disaggregated data. As members of the NHPI community have most typically been grouped with other racial and ethnic groups, effectively masking their unique experiences and needs. The NHPI Data Policy Lab at the Center for Health Policy Research is working to address these gaps. The lab has launched 4 data dashboards and a data policy platform focused on providing accessible tools on the health and health needs of the NHPI community. It is a powerful resource for change agents, policymakers, community activists, and data-driven institutions who are working together to improve data systems and processes to better reflect NHPI communities' challenges and strengths and address their needs. Other examples of ensuring that data is representative are provided by the California Health Interview Survey, which we call CHIS. And this is the largest state-level population health survey in the US. It's a leader in the disaggregation of data through its representation of multiple racial, ethnic, linguistic, sexual orientation, and gender identity groups. In addition to the ongoing survey, which collects data from about 20,000 California households annually, CHIS also supports several follow-on studies that can allow us to take a closer look at the health concerns of specific subgroup populations. For example, these fact sheets report findings from a 5-year NIMHD study on immigrant health, which specifically investigated the exclusion experiences and perceptions of Latinx and Asian immigrants in California, and how multiple institutional sectors and policies intersect to affect their access to health care. Another CHIS follow-on study, funded by California's Department of Healthcare Services, is investigating the long-term service and support needs of older adults and people with disabilities in California. And these data are currently being used to inform the state's 10-year master plan for aging by providing indicators to populate their data dashboard on aging, which is tracking progress towards achieving its goals for improving the health and well-being of older Californians and people with disabilities. To achieve health equity, we must also make data easy to access. Examples include the visualization of data through data dashboards and infographics like those displayed here, which shorten and simplify the presentation of research findings for a general audience. We also support access to CHIS data through data user trainings that introduce community members and non-researchers to user-friendly data tools like AskCHIS and AskCHIS Neighborhood Edition. A fourth element essential to achieving health equity is the translation of research to policy and practice. It is the ongoing engagement with the community the communication of research findings to a broader audience, and the relationships that are developed along the way that are needed to make data actionable. And this step goes beyond inviting community members to join our research enterprise and be part of our advisory boards. It means we also need to go out and truly engage with the community, serve on their boards, follow their leadership, and contribute to the goals they have for the community. Finally, arguably most importantly, we need to support the next generation of health equity researchers and champions. Last year, we launched the Health Equity Challenge with the support of Molina Cares, and this year, with additional support from the California Healthcare Foundation, we have currently a cohort of 14 UCLA graduate students from public health, social welfare, public policy, medicine, and education. And the goal of the program is to support these graduate students who are committed to finding practical, community-based solutions to address long-standing and persistent health disparities. Over a 15-week period, the students are paired with an academic or community mentor to help them develop their intervention or program and to turn their idea into a full proposal. The students also identify a partner and partner with a CBO that can implement their idea. The final proposals are reviewed by an independent review committee, and up to 4 community-based organizations are awarded $50,000 to implement the winning students' ideas. You may recognize some of the students that are up there, if you can see them. So the passion, commitment, and innovation that these students are bringing to the table really promises hope for our future, and all of us working together to achieve health equity. Thank you so much.
Thank you, Dr. Kietzman. I'm going to invite all 3 panelists back up to the stage. We're going to open up for questions. So we're not going to pass around microphones, but when I call on you, if you can please just introduce yourself and ask your question, that would be great. Yes.
Department of Epidemiology. Dr. Kietzman, what barriers do you see in not just health equity, but throughout the university, barriers to working with Native communities? And what advice would you give the School of Public Health, whose administrators are here today, in moving forward with scholarship and collaborative work with Native communities? Because in 60 years, I'm not aware of a lot of collaborative work with our Native communities.
Thank you for that important question. I would point back to the example I just presented of creating a space for representation of the Native Indigenous community. And within that representation, there needs to be opportunities to support at all levels the generation of students coming up, the faculty. But I think there are opportunities through this community engagement that I've described to support the ideas, to bring a stronger focus on this population. I mean, there are so many populations that can fall underneath the umbrella of experiencing health inequities, and I think that cross-campus collaborations could be helpful, going across to other departments, other schools that have representation, that have some programs that can shine a light on the Native community's needs. So I don't know if that's helpful, but.
Could I chime in? You had mentioned about like the importance of data equity, and I think that a lot of times Indigenous communities are not adequately represented in the data that we have. And that's a choice. We can choose to make sure that we produce data that are representative. So I have a project coming up soon looking at the impacts of the child tax credit on birth outcomes. And because we have really good birth records data, we are able to look at Indigenous populations. They have to check off AIAN, right? But and I think that that's the kind of work that we need voices from those communities to do that work well and to understand and interpret how things are coming out. So I would love to connect afterwards to find out if we can do that.
Any other questions?
Hi, my name is Christy. Dr. Kietzman,
Sure.
And mentioned all the different students who are involved, and I didn't hear you name any dental students. And I'm curious because oral health is the gateway to overall health. I'm sure we all agree on that. And it's and access to healthcare, oral health care services is huge disparities in this country and abroad. And I'm just curious, what role do you see dental medicine playing?
Oh, I think absolutely. We'd love to recruit applicants. Hopefully we'll have a third round of the Health Equity Challenge. It's open to all graduate students across the university. And we actually are trying to reach out and reach disciplines and professions that aren't necessarily the most immediate groups that you would think about, because we want innovative solutions. We want new thinking about how to address these problems. Last year we had a cohort with a different mix of disciplines and professions, but we certainly want to improve our outreach and make sure that all UCLA graduate students know this is a competition that they can apply to. And so if you give me whatever contact information to make sure I can pass that along. I mean, we try to do it through department leads, but also through personal connections. That always seems to move things forward a little bit faster. And it's new. It's new, and we're hopeful that it's going to continue, but we want as much representation as we can in the cohorts moving forward. Thank you for the question.
Other question? Yes.
Hi, Ernesto Sosa with the Center for Health Equity here at UCLA. So thank you for your presentation. I think we can see from that health disparities are multifaceted, and because of that, there can't be one silver bullet magic solution to address them. So I'm just wondering, from your experience, this is for all three of you, what collaborative approaches and interventions have you found to be the most effective to trying to address health disparities as a whole?
I can get back on my soapbox about collaborating with the community. I mean, I think that there's increasingly understanding that we need to listen to people that are affected by social problems, health inequities, and start there. But what hasn't followed along is the funding for that, typically. I'm really encouraged that there are some new mechanisms that are coming around that recognize that we need to do some more, we need to have funding to support that developmental work, that building of relationships with community. It takes time, and as previous panel someone pointed out, there's not enough time to do all of these things from A to Z. But I think that's why we need to have partnerships where different people take the lead on different facets of what we need to achieve health equity. I can't do it all. I can't do a program and an evaluation and also advocate and to the policymakers. But somebody needs to, I think, take all of those steps. So the more we can reach out and create larger, more comprehensive teams to address all of those components, I think that's where I would start. And I do think there's increasing recognition. There's a Compass NIH new mechanism, which is amazing. I'll just pull that out as a specific example, because what they do is they sort of do a paradigm shift, and the PI is the community. The community organization serves as the PI. And when I read that opportunity, I thought, wow, this is game changing, because it's about where the power is. And I think we have to think carefully about our role as researchers and the power that we have and how that can block us really getting to the core of where health inequities begin and what we need to do to address them. We need to be a much more inclusive community, in my view. Others?
Yeah, I would echo a lot of what Dr. Kietzman just said, and I think just for me, reiterate the real benefit and power of collaborating with, in my field, environmental justice organizations. I'm lucky that I live or have done my work here. There are so many incredible long-standing environmental justice organizations in California. I'm a recent transplant to Los Angeles, so I have just getting to know many of them here, but it's really, I think, makes my work have much more impact, because number one, they're helping drive the research agenda. So ensuring we're asking the right questions, the questions that are likely to influence public policy and shift the needle in public policy. Making our methods more rigorous, and because they are experts on the issues in ways that folks in academia are not, don't have the lived experience. And then third, really ensuring that our findings are reaching policymakers and influencing regulatory science. So to me, it's really, it's not well-resourced work. And I think but it's very rewarding work, because otherwise, you publish your science, it sits on the shelf in a peer-reviewed journal and nobody ever reads it, right? And I think one challenge that I've had in pursuing that type of collaborative work is that it's all the academy is so siloed, and the questions that communities have and the issues they're struggling with do not fall along disciplinary lines, and we don't have good structures to facilitate and sort of institutionalize community-based participatory research or community-engaged scholarship. It's often, done through personal relationships of PIs and faculty members. But I think we could do a lot more in terms of creating institutions to foster and catalyze those types of partnerships across campus, across disciplines, across faculty members.
Yeah, I would certainly agree with all of that. I think that we do have this problem of kind of so like Du Bois described it as sometimes what we produce for the academy is Greek to the people who we want to ultimately help. But I think that there is maybe a way, like whenever you get lucky and it works together, in my experience, it's been really impactful. So I wrote a study about baby bonds. It's like this idea for a federally funded trust fund account. It'd be universal, but there would be more for households with less wealth. And I didn't understand the community organizing that was already there behind it when I wrote the paper, but it ended up kind of contributing to that momentum. And there has been, DC, for example, passed a bill now that, so newborns, when they turn 25, they're gonna get, a couple thousand, like $20,000 for households who have meet a certain income level and who have Medicaid coverage when they're born, for example. So that's huge. I'm like, that's like very heartening for me that there are these poor kids who are gonna get like tens of thousands of dollars, and maybe I contributed in some way to that process. That's like really exciting and inspiring, I think. And ideally, it's kind of from like listening to what people need and where they have energy, to try to like spark that kind of magic again in the future. One thing that I heard about very recently, so UCLA is doing their strategic visioning, and they'll be done with it soon. And part of that, though, is going to be trying to strengthen the relationships between UCLA and the city of Los Angeles. How exactly that's going to play out is, I think, still to be decided. But of course, the Olympics are coming up, all of this stuff. So I think that there are opportunities to make like stronger, larger, kind of at that strategic vision level kinds of relationships between different kinds of community organizations, that have momentum, that have centers of, where they can collect attention from community members to reach out through the university, different administrators, and to try to find ways to like really effectively and in a meaningful way live out that idea of like having UCLA as a strong part of the city. Especially since we don't pay taxes. We gotta help out in a different way.
Yeah.
Hey, I'm Dr. Beth Ferreira. I'm a medical director for Elevance in substance use disorders. I really appreciate the connection between income and health disparities. But I know you did mention this with high income Black and colored people still having less access, or let's say English is a second language. There's quite a few not going to the hospital. And when we survey, when we look, it's because of the way they're treated in healthcare. Do you know that, or are you working on things that help educate people who are healthcare providers, or training for health providers to be more culturally sensitive and to try to eliminate that stigma?
Oh, I have a great example from one of our Health Equity Challenge winners from last year. And her project was developing a mental health training for clinicians to do the things that you were talking about, to reduce the stigma, to make the services more culturally appropriate, to train the providers so that they would understand more how to interact with people, specifically with mental health issues. So, I mean, I think there are ideas out there. It's now being implemented through Charles Drew University with their medical clinicians. So that's one small example.
Yeah, I think that what you're raising is it's a real issue. Like I've seen studies where they go to like a medical conference and they have actors pretend to be patients, and they come in with presenting the exact same symptoms, same age, and they practice and everything to make sure that they describe it in the same way. And they find that these physicians systematically recommend different kinds of treatments depending on the race of the actor playing the patient. And they've played this out in like a bunch of different kinds of contexts. So yeah, providers are treating people differently based on their race, despite all of this really solid medical training that they've gone through. And so it's and maybe part of that is pipeline. We can have more medical providers that look like their patients, and not just at every level of medical care provision and administration. I think it's a complex problem, and that each of these things, is going to contribute to inequities that holding income constant, and wealth, which is actually a hidden, huge hidden driver that, of racial disparities in access to a variety of different kinds of resources. Wealth inequality by race is unimaginably high. We've made a lot more progress in terms of income and education than we have on wealth, because wealth is generationally transmitted and all that. So, but regardless, even holding all of those economic circumstances constant, we still have these inequalities in access, in ability to navigate systems because of just cultural capital relative to who is the person making the decision and what kind of words should I throw at you to make you do the thing that's going to be good for me, So there's just cultural differences in what's happening in the institutions and what's happening, from the patient side, as well as just providers themselves. So it's at every level, and it's so complex. But I think that it's about, training providers, having more diverse healthcare workforce, and removing differences in the social determinants of health.
That's a great question, and at various points has been a big debate in the field. We did not look at that in that particular study, and I think it's complex, and there's probably multiple drivers of these disparities. One recent project that I worked on, we looked at racism in the housing market and the practice of redlining, and looked historically, and were able to show that siting of fossil fuel power plants was disproportionately, they were disproportionately sited near redlined communities, even up until power plants sited in the last 20 years are still disproportionately sited next to communities that were redlined in the 1930s, a practice that was outlawed in the 60s, but persists in various forms. So I do think that forms of structural racism in the housing market and other sectors contribute to these patterns. I'll also say, if you like that graph, go check out one of the posters from one of our PhD students, because there's a similar, I'm looking at EV, electric vehicles, and how they're, who's able to purchase electric vehicles and how they're contributing to reducing air pollution, but not evenly, as we might like. So, yeah, I think in my work, it's important to understand the causes, of course, because they help you identify solutions. But more of my energy these days is towards the solution, like the solution side, and trying to develop frameworks and data tools that can help try to redistribute things, or at least make it harder to site a polluting facility in a neighborhood that already has a bunch of them, for example. And I think we're hopefully in a moment, there's a panel later on today about climate change, in a moment of big transformation in terms of the fossil fuel economy, that's going to present a lot of opportunities for cleaning our environment, creating better air quality. And so I think there's a lot of momentum around the ideas of climate justice. How do we harness this energy transition to try to address some of these historical wrongs? Yeah, I don't know if I answered your question. I kind of went in another direction, but I think the causes are multifaceted. It is important to understand them, and it's also important to, I think, address the problem, even if we don't really know everything that gave rise to the patterns that we see today.
Unfortunately, we are now out of time, but I want to thank our three panelists for their excellent presentations today.